Welcome everybody to part 4 of Dr. Manny's YouTube Learn Shops, which deals with invasive mechanical ventilation. The objectives for this session are to define what invasive mechanical ventilation is, IMV, review the history of IMV, look at positive pressure ventilation, some of the objectives associated with it and the indications for its implementation, look at the contraindications, and then review some of the system components. Look at some of the ventilators that are available and the different modes of delivery and their adjuncts. Concluding with troubleshooting using the DOPE acronym and certain weaning methods that could be employed. Well, mechanical ventilation is termed invasive if it involves any device going inside the trachea, through the mouth, such as an endotracheal tube, or through the skin, such as a tracheostomy tube. Mechanical ventilation or assisted ventilation is a medical term for artificial ventilation where mechanical means are used to assist or replace spontaneous breathing. This may involve breathing assisted manually by a suitably qualified professional by compressing a bag valve mask device. Here's an example of an endotracheal tube with invasive mechanical ventilation. Here's an example of a tracheostomy tube. Let's briefly review the history of invasive mechanical ventilation. However, in the early 1900s, which we already discussed briefly here, there were negative pressure devices. Then when it came to the 1940s in Boston, in the United States of America, there was an epidemic related to poliomyelitis, where negative pressure iron lungs were used for patients with paralysis. In the late 1940s, other pressure cycled ventilators were introduced. Assisted ventilation became more in vogue in the 1960s, and it's evolved since that period of time with a number of different modes available, whether it's controlled mechanical ventilation, assist controlled ventilation, intermittent mandatory ventilation, synchronized intermittent mandatory ventilation, pressure regulated volume control, pressure support, the list goes on. What are the objectives of invasive mechanical ventilation? Well, the objectives are primarily to improve pulmonary gas exchange, relieve respiratory distress, permit lung and airway healing, and avoid complications associated with ventilator-acquired or associated lung injury, ventilator-induced lung injury, and ventilator-associated events. There can be numerous issues, complications related to intubation, mechanical complications related to the presence of having an endotracheal tube in situ, ventilator-induced lung injury, as I indicated, with Varley, Villi, and Vey, complications associated with oxygen and toxicity, infectious complications because you're breaching the natural or the normal protective mechanisms, such as the nasopharynx. What are some of the indications to initiate IMV? Well, they could be acute respiratory failure. In previous courses, we discussed type 1 and type 2 respiratory failure, which relates to hypoxemia and hypercarbia. Or it could be a combination of both. It could be prophylaxis to provide ventilatory support in shock states or post-operations. It could be a therapeutic ventilation support, such as for an acute head injury where there's a high intracranial pressure and you want to lower the CO2 or you want to increase the oxygen. Or it could be post-cardiac arrest when the patient is still unconscious. What are some of the initiation criteria to consider invasive mechanical ventilation? This is variable. It depends on the admitting physician or the unit policy for their intensive care or the emergency department, but typically it means the respiratory rate is usually fast, greater than 35 breaths per minute, a tachypnea, in conjunction with other parameters and criteria, such as a tidal volume of less than 5 mils per kg, a vital capacity of less than 15 mils per kg, which means the person is not able to generate an effective cough, a maximum inspiratory force that is typically less than minus 20 centimeters of water, indicating that inspiration may be difficult. Arterial blood gas analysis, always a consideration, indicating hypoxemia with a PaO2 of less than 60 millimeters of mercury, and an acid-base problems related to a respiratory acidosis where the pH is less than 7.25 and the PaCO2 is greater than 50 millimeters of mercury. What are some of the contraindications for initiating invasive mechanical ventilation? Well, untreated pneumothorax, before then even no patient or family consent, or the patient is in a condition now that really will not benefit from being intubated and placed on mechanical ventilation. What then are some of the essential components required for invasive mechanical ventilation? Well, you need a patient, number one, that is appropriate. You also need an artificial airway. You need a ventilatory circuit, a mechanical ventilator, a power source, and a gas supply. Artificial airways consist of the following. They could be supraglottic airways, such as a laryngeal mask or laryngeal tube. It could be an endotracheal tube, which could be nasal or oral, a tracheostomy tube, or a crycothyrotomy. Here's an example of a supraglottic airway, such as a laryngeal mask. Different variations. Your tracheal tubes, whether endotracheal or directly into the trachea. A crycothyrotomy, which would employ a tracheostomy tube as well. So, when we look at ventilator circuits, there are many different types. But you've got circuits that are considered to be plain, with a single water trap, with a double water trap, with a heat moisture exchanger, with a flexible catheter mount. Plain breathing circuits are plastic and disposable. You've got plain breathing circuits and systems that have got water traps in them, also disposable. You've got plain breathing systems that have got heat moisture exchangers in them, HMEs. You've got adjuncts that require humidification, where all air delivered by the ventilator passes through the water, sterile water, in a humidifier, and gas is warmed and saturated to a normal body temperature, typically between 35 and 37 degrees centigrade. So what then is a mechanical ventilator? Well, a mechanical ventilator is an automated machine that helps a patient breathe or ventilate when they're having surgery or they cannot breathe on their own due to a critical illness. So essentially, it's a device that breathes for the patient when they can't breathe effectively for themselves, or the physician or the surgeon doesn't want them to breathe, like in a general anaesthetic. What are some of the types of mechanical ventilators available? Well, you've got transport ventilators, ventilators employed in intensive care units, high frequency jet ventilators, and home care ventilators, and many more variations. Transport ventilators are designed to take the place of manual ventilation or bagging during emergency or transport situations. And these ventilators are typically designed for inter-hospital or intra-hospital or pre-hospital emergency transport. ICU ventilators are a type of equipment that are used in intensive care units, and they're to assist people in breathing when they're unable to do so for themselves. The ventilator is attached to an artificial airway in a tracheal tube, tracheostomy tube, laryngeal mask, so it can deliver breaths into the lungs. It breathes into the lungs for the patient. It ventilates. Here we have an example of high frequency jet or high frequency oscillatory ventilation. These are passive ventilators. These ventilators are controlled by a microprocessor, and they're capable of delivering and monitoring between 240 to 660 breaths per minute and more so. Typically they're not breaths per se as we understand a breath to be, but they deliver very small volumes of gas at supraphysiological frequencies. And these are typically used for patients that have got very severe lung disease, where ventilating them normally may promote even further ventilator-induced lung injuries or ventilator-associated lung injuries. Villian Valley. Home care ventilators, well, home mechanical ventilation is a treatment option that's becoming increasingly available in all countries in the world, and one that's being chosen by families with increasing frequency as an alternative to staying in hospital or institutionalized care. And this can apply to pediatrics, and it can apply to adults, and it can apply to geriatrics as well. So, what are some of the types of mechanical ventilation that are available? And mechanical ventilators are classified according to how inspiration ends. So they can be volume cycled, they can be pressure cycled, they can be time cycled, they can be flow cycled, or a combination of all of them. Volume cycled ventilators are typically used in adults. They deliver a preset tidal volume. An example might be 500 mils of gas. Inspiration occurs until the tidal volume is delivered, and tidal volume is not dependent on the patient's pulmonary or thoracic compliance or airway resistance. The advantage is, with volume cycled ventilators, that if you set a preset tidal volume, it is constant and it will be delivered. The disadvantage is because it's delivered, regardless of the situation or the condition of the airways or lungs, there's a greater risk of barotrauma. Barotrauma being pressure trauma, which could be pneumothorax, pneumopericardium, subcutaneous emphysema, pneumoperitoneum, the list goes on. Barotrauma. Then you've got pressure cycled ventilators, and these are more commonly used in neonates and paediatrics in their relevant intensive cares. And this delivers a preset pressure, for example, could be from 10 to 20 centimeters of water. And inspiration occurs until a preset pressure is reached and delivered. The tidal volume, however, is dependent on the pulmonary and thoracic compliance. So therefore the advantage of pressure cycled ventilators and ventilation is there's less risk of pressure trauma because you're controlling the pressure. However, the disadvantage is you're not going to be sure of what the actual tidal volume is that is actually being delivered to the patient, because this is dependent on the airway resistance, the pulmonary compliance, the thoracic compliance. Then you've got time cycled, and time cycled is also used primarily in paediatrics and neonates in their respective intensive care units. And time cycling basically indicates that the ventilator breath switches from inspiration to expiration after a period of set time for inspiration and expiration. And this will deliver a preset pressure over a specific inspiratory time, which is sometimes referred to as pressure limited. And this can be accomplished by setting the respiratory rate, the inspiratory time, or the IE ratio, the inspiration-expiration ratio. So what are some of the terms that we might commonly use which are associated with mechanical ventilation? Well, the terms are according to who, what does the actual breathing. So the common terms are controlled, assisted and supported. Control, assist, support. Control breaths, look at the terminology. Control. This is controlled by the ventilator. The patient does nothing and the ventilator does everything. So depending on the parameters that are required to be set for that specific ventilator, typically the breathing rate has to be set, the tidal volume has to be set, or the pressure has to be set depending on the type of ventilator mode it is. The IE ratio has to be set and an oxygen percentage has to be set. There are many, many other parameters that are now available to be set. However, these are the basics. Then you've got assisted breaths. Assisted breaths are controlled breaths that are triggered by the patient's spontaneous breathing effort, which means the patient can start the breath. But the ventilator then says, thank you very much, you've started it, but I will do all the work of breathing. So therefore, the ventilator delivers a breathing rate that is initiated by the patient, if they are able to do so, but it will deliver a preset tidal volume or pressure, IE ratio and oxygen percentage. The patient starts the ventilator breathing, but the machine does most of the work. Then you've got supported breaths. Support means, well, the machine's only just helping a little bit. So these breaths are triggered by the patient's spontaneous breathing efforts, and the ventilator will give some support but not full support. Therefore, the ventilator will deliver a preset breathing rate, tidal volume pressure, IE ratio and oxygen percentage. But the patient does most of the work. So if you see the terms control, the machine is in control. If you see the term assist, the machine is still in control but assisting a little bit. If you see the word support, the patient's doing most of the work. Machine only helps a little bit. So what are some of the modes of ventilation? Modes of ventilation basically are the method or way a machine breathes for the patient. And this determines how much the patient participates in the breathing process. The mode decides how much work of breathing the patient has to do. As we said, control, the patient doesn't have to do anything. Assist, the patient does a little bit, but not much. Support, the patient does most of the work. What are some of the common ventilation modes? Control, mechanical or mandatory ventilation. Look at the words. Ventilators in control, mandatory ventilation. Machines in control. Assist, control, ventilation. Patient only assists a little bit, mainly control. Then you've got IMV, intermittent mandatory ventilation, which has been extended to synchronized intermittent mandatory ventilation. But basically, there's intermittent control ventilation, but it's synchronized to the patient's breathing efforts or attempts to make it a little bit more user-friendly, so the patient becomes a little bit more cooperative. Then you've got pressure-regulated volume control and pressure support ventilation. Pressure-regulated volume control, machine is still in control. Pressure support ventilation, patient is primarily doing most of the work. Control, mandatory or mechanical ventilation as far as terminology goes. The ventilator's in control. The patient cannot generate spontaneous breaths, volumes or flow rates. If they do, they'll end up fighting with the ventilator. So therefore the ventilator delivers a preset parameter range, such as breathing rate, tidal volume or pressure, inspiration-expiration ratio, and the oxygen percentage. The ventilator is in control. CMV. The CMV waveform and control mandatory ventilation, look at the graph. You've got control breaths, positive pressure. They go above the baseline 0 to whatever volume or pressure is set. If you set a volume, you don't know what the pressure will be. If you set a pressure, you don't know what the volume will be. This depends on the patient's lung compliance. But there is no spontaneous breathing effort here. This is control. Then you've got assist control ventilation. The control breaths, which are set, are triggered by the patient's spontaneous breathing effort, which means if the patient wants to breathe, they create a negative pressure, and this tells the machine to deliver the patient's breath. But the machine will still deliver a preset breathing rate, a tidal volume or pressure, inspiration-expiration ratio and oxygen percentage, but the patient can start the breath, but the ventilator does the work. Here's an example of an assist control ventilation waveform. You've got the control breath, and then you can see the negative deflection below the line circled by the black circle. That's the patient's breathing effort. And because they make a negative pressure, the machine recognizes that, and because it recognizes it, it will give the breath early. As you can see, the waveform is irregular. So the patient can initiate when they want the breath. ACV, or assist control ventilation. Synchronized intermittent mandatory ventilation. It's intermittent mandatory ventilation and it's synchronized. Well, what does that mean? It delivers a mandatory preset breathing rate, tidal volume or pressure, inspiration-expiration ratio, oxygen percentage. But it allows the patient to breathe spontaneously between mandatory breaths. It also monitors the patient's spontaneous breathing efforts, and when a mandatory breath is due, the ventilator will coordinate the mandatory breath with the spontaneous breathing effort. And this is good because it promotes compliance with the patient and the ventilator. And it prevents what is called breath stacking, which means here the ventilator and the spontaneous breath are combined. Because if they're combined now here, this may result in fighting the ventilator. So synchronized intermittent mandatory ventilation is considered a good weaning mode, even though it hasn't been proven in the research or evidence-based practice to be any more effective than any other modes. Pressure regulated volume control. This is a mode of ventilation that relies on volume, but the pressure is regulated by the machine. So what the machine tries to do is deliver the set tidal volume at the lowest possible pressure. The breathing rate, I ratio, oxygen percentage are all set, but the tidal volume will try to be delivered by the machine at a flow pattern or a decelerating flow pattern to decrease the amount of pressure, which means as it delivers it slower. So it allows the lungs and the airways to inflate, expand, inspire, possibly at a lower pressure. And the objective is to prevent ventilator-induced lung injury. Here's an example of the waveform where the machine tries to deliver the tidal volume by lowering the flow rate during inspiration to achieve the target tidal volume at the lowest possible pressure. In theory, it works fine. In practice, it's sometimes difficult because sometimes patients have very severe lung disease. Pressure support ventilation, PSV, also known as pressure support, is a spontaneous mode of ventilation. An example that we spoke about earlier on was BiPAP, bi-level positive airway pressure. And pressure support ventilation is incorporated with most other modes of ventilation. Like for example here, pressure regulated volume control with pressure support. SIMV with pressure support. So pressure support, this is where the patient triggers every breath and the ventilator delivers support to a preset pressure limit. The patient regulates the respiratory rate and the tidal volume. And as I said, it can be combined with other modes of ventilation. But this is for patients who are breathing spontaneously because it supports their spontaneous breathing when they may be recovering from long-term ventilation, and it helps them build up their ability to breathe spontaneously with a little bit of support. Pressure support ventilation. Here's an example of a pressure support ventilation waveform. Remember, the patient is breathing spontaneously. And BiPAP is an example of pressure support ventilation. because with IPAP it supports inspiration, with EPAP it supports expiration. It makes it easier for the patient to breathe spontaneously. There are also ventilation mode adjuncts such as PEEP or CPAP. PEEP is positive end expiratory pressure, and this is a ventilation adjunct that is used in all patients that are on invasive mechanical ventilation. And it increases the surface area by recruiting and stabilising collapsed alveoli. It can open bronchioles. It restores what we term to be physiological PEEP, which again is a pressure in our normal airways that prevent airway collapse and alveolar collapse. CPAP is continuous positive airway pressure, which we've mentioned previously in other courses, but basically it's PEEP with spontaneous breathing in intermittent mandatory ventilation, and it's often used to evaluate extubation potential in patients that are mechanically ventilated, certainly long term. In most cases here, pressure support ventilation replaces that these days. Positive end expiratory pressure is the pressure in the lungs above atmospheric pressure. It's supra-atmospheric, and it exists primarily at the end of expiration, and the objective is to keep the airway open. You've got two types of PEEP: extrinsic PEEP and intrinsic PEEP. Extrinsic PEEP, or applied PEEP, is a standard ventilator setting. It's chosen when all populations, neonate, paediatric and adult, are being provided with mechanical ventilation using an invasive technique. Typically it's set at 5 centimeters of water in all populations, neonate, paediatric or adult, and it's used to lessen alveolar collapse at the end of expiration in a mechanically ventilated patient. Intrinsic or auto PEEP is another form of PEEP, and this occurs when the expiratory time is shorter than the time required for expiration, and it prevents the lung and chest wall from reaching an elastic equilibrium point, which results in gas trapping. Normally in you and I, we have an intrinsic PEEP of around about 5 centimeters of water. In patients with chronic lung disease, it's much higher, because the objective is to prevent gas trapping. What then are the benefits of positive end expiratory pressure, PEEP? Well, the benefits are that it reduces atelectasis. It recruits collapsed alveoli. It restores or increases the functional residual capacity, which is the amount of air that remains within the lung during expiration. Therefore, it also increases lung compliance, may decrease the work of breathing, increase the PaO2 for a given FiO2, and decrease the shunt fraction, which occurs because of dead space within the lung, which is areas of lung that cannot or can't participate in gas exchange. There's an example: collapsed alveoli, PEEP applied, maybe you'll recruit collapsed alveoli. What are some of the adverse effects related to PEEP? Well, depending on the level, you increase intrathoracic pressure, which in certain conditions may be detrimental to patients who've got an increased intracranial pressure. It can increase pulmonary vascular resistance, decrease the amount of blood returning to the heart, called preload, and therefore decrease cardiac output. If it decreases cardiac output, it can decrease renal and portal blood flow. It may promote hemodynamic instability, and as we mentioned previously, it could initiate barotrauma in the form of ventilator-associated lung injury, ventilator-induced lung injury, or ventilator-associated events. It also decreases ventilator trigger sensitivity, because the ventilators in some modes have got a sensitivity setting which makes the machine aware of the patient's breathing efforts. And depending on the level of PEEP, it can increase the work of breathing. There's the CPAP waveform, which we've already looked at previously, and there's the BiPAP waveform. CPAP waveform is a continuous one-pressure waveform. The BiPAP waveform is a bi-level waveform. One is IPAP, inspiratory positive airway pressure, which increases or helps inspiration primarily, and EPAP is an expiratory positive airway pressure, which typically assists expiration. But IPAP is typically higher than EPAP. CPAP is the same pressure. Indicated in that waveform above that we're looking at now, CPAP is 5 centimeters of water, IPAP is 15 centimeters of water, EPAP is 5 centimeters of water. What then are some typical ventilator settings? Now remember, there's no normal. It depends on the ventilator, it depends on the patient, it depends on their condition, and it depends on the intensivist or the person who's responsible for setting the ventilator settings, their preferences. But typically, ventilator settings consist of a frequency or rate of ventilation, tidal volume in mils per breath, a pressure in centimeters of water, an IU ratio, an inspiration-expiration ratio, the sensitivity or trigger in centimeters of water, the oxygen percentage, the PEEP in centimeters of water, and alarm limit settings. If we look at the frequency of ventilation, or how often we're going to provide a breath, it's controversial. So depending on the patient population, adult, pediatric or neonate, it varies. But typically an adult may be set between 8 and 20 breaths per minute, a child or infant between 20 and 40 breaths per minute, a neonate between 40 and 60 breaths per minute. But it depends. The tidal volume is typically set between 5 and 7 mils per kg for adults and older children weighing more than 20 kilograms. Advantages are, as I mentioned previously, the tidal volume is guaranteed. The disadvantage is you don't know what the inspiratory pressure is going to be, because this is dependent on the thoracic and pulmonary and airway compliance. The disadvantage could be it could generate a high pressure, which could cause barotrauma, pressure trauma, Varley, Billy, or ventilator-associated events. The peak inspiratory pressure, or the PEEP, is the highest level of pressure applied to the lungs during inspiration. And typically it's acceptable, typically to be 10 to 20 centimeters of water, and typically kept below 30 centimeters of water, because anything above 30 centimeters of water could result in barotrauma, pressure trauma, Billy or Varley. The IU ratio is the inspiration-expiration ratio, and this refers to the ratio between the inspiratory and the expiratory time. In you and I, in normal spontaneous breathing, the expiratory time is typically 2 to 3 times as long as the inspiratory time, to ensure that we have time to exhale before we inhale again. In COPD patients, chronic obstructive pulmonary disease patients, they have a prolonged expiratory time typically, and it can be anywhere between 1 to 3, 1 to 4 or 1 to 5. So it's important to be aware of that as the person setting up the ventilator or their settings. Trigger sensitivity refers to a mechanism which allows the ventilator to be aware of the patient's inspiratory efforts. In modern ventilators, a demand valve is triggered by either a fall in pressure trigger, or a change in the flow trigger. So therefore this can be set, and this basically makes the machine aware of the patient's inspiratory efforts within the ventilator circuit. If there's a change in pressure or if there's a change in flow, the machine, if it's sensitive enough, can sense it, and it will allow the machine to give a breath or assist the patient depending on what mode they're in. Trigger sensitivity, for example, there we have on the waveform airway pressure, no spontaneous breathing effort, but if, for example, it's trigger sensitivity that are pressure sensitive, it's set in centimeters of water. So for example, if the patient creates a negative pressure of minus 1 centimeters of water, and the machine is aware of that, it'll say, hey, the patient's trying to breathe, I will help him to breathe spontaneously, or I will help him to breathe and assist his ventilation. If I make it more strenuous as the person setting up the ventilator, I may say, well, I want him to have a trigger sensitivity of -2 or -3, which means the patient has to create a higher negative pressure in order to activate the machine's sensitivity. And this can help a patient to build up their work of breathing, their respiratory muscles, especially if they've been on a ventilator for a long time. Trigger sensitivity, how sensitive the machine is to the patient's breathing efforts. Here's an example, highlighted flow trigger. When we come to the oxygen percentage, this is really the fractional inspired oxygen, the FiO2. And typically it's monitored by arterial blood gases, because you don't want to provide oxygen in too high a dose, because this can cause oxygen toxicity. So the FiO2 is monitored by arterial blood gases, and typically neonate, child, adult are basically the same, meaning the PaO2 is essentially monitored to be between 80 to 100 millimeters of mercury, unless of course the doctor permits hypoxia. In certain conditions, permissive hypoxemia or hypoxia is something that could be employed to prevent oxygen toxicity. Positive and expiratory pressure, well, we've already covered that previously. Typically, a routine standard setting is 5 centimeters of water, and this is to prevent atelectasis. Here it can be a little bit higher, 8 to 10 centimeters of water, but caution is advised for any pressures higher than 10 centimeters of water, because this could induce lung injury or it could promote hemodynamic instability. Depends on the patient's condition, depends on whether they're stable hemodynamically or not. Alarm settings are very important for all machines, not just ventilators. So typical alarm settings in a ventilator are low or high pressure, low or high minute ventilation, low or high oxygen, low or high breathing rates, low or high tidal volumes, low or high PEEP levels if there's a power failure. When it comes to alarms, always remember to respond to alarms. Don't become complacent. However, always look at the patient first, and if in doubt, and you're permitted to do so, disconnect the patient from the ventilator manually and handbag with 100% oxygen until someone who's an authority comes to assist you. Whether it's a respiratory therapist in some countries, whether it's your immediate supervisor, preceptor, whether it's now the physician or the intensivist. When it comes to troubleshooting a patient on a ventilator, if they develop respiratory distress, as I said, always look at the patient first. If in doubt, disconnect the patient from the ventilator if you're allowed to do so, and manually handbag with 100%. And remember this acronym, the DOPE acronym, the DOPE acronym. And this is for respiratory distress in a patient that is being mechanically ventilated. D stands for displacement, O for obstruction, P, pneumothorax, E for equipment failure. Always consider that. When it comes to displacement, that basically means maybe the tracheal tube has been moved or dislodged because you were turning the patient. If you're not sure, if you're in doubt, disconnect the patient from the ventilator manually and handbag with 100% oxygen. If they improve, then it's not a problem. If they don't improve, then it's probably a patient problem. Obstruction. Is the tracheal tube obstructed or kinked? If in doubt, disconnect the patient from the ventilator and manually handbag with 100% oxygen. Suction the tracheal tube if required. Is there a pneumothorax? Well, you could auscultate the patient's chest. Just observe for chest rise during positive pressure ventilation. But if there's a pneumothorax, this is barotrauma. And this could be ventilator-associated lung injury, or it could be ventilator-induced lung injury because of high peak inspiratory pressures or high positive end expiratory pressures. Then consider equipment failure. However, always look at the patient first, and again, if in doubt, disconnect the patient from the ventilator, manually handbag with 100% oxygen until assistance arrives. If the patient improves with bagging, then it's probably going to be related to equipment failure. The machine has got a problem. If they don't improve, then it's probably a patient problem. Now let's consider discontinuing invasive mechanical ventilation. There are three key points from my perspective to consider. The problem that caused the initiation of the invasive mechanical ventilation initiation has resolved. The patient meets the measurable medical criteria for your department, policy, organisation for discontinuation. Or a spontaneous breathing trial has established that weaning is appropriate for this patient. So weaning from IMV can be defined as the process of abruptly or gradually decreasing the amount of support that the patient receives from a mechanical ventilator. Some patients do well by suddenly stopping mechanical ventilation. Other patients require longer term discontinuation. However, once a patient is able to sustain spontaneous breathing, a second judgment must be made regarding whether an artificial airway can be removed. Weaning criteria as a general rule. Every organisation is different, every ICU is different, every intensivist could be different, but most go on what is evidence-based. So weaning criteria as a general rule, neurologically, they should be alert, have protective reflexes such as gag, cough and swallow, and have a Glasgow Coma score that is essentially greater than 12. Cardiovascular, they shouldn't be tachycardic, they should be normotensive. Vasopressors, if they were on them, should be either discontinued completely or on low dose. For example, things like dobutamine, dopamine should be at the lowest possible dose, let's say 5 mics per kg of body weight. Vasopressors like epinephrine and norepinephrine should really be discontinued. The respiratory rate should be greater than 8 and definitely less than 40. Tidal volume greater than 5 mils per kg, vital capacity at least 10 mils per kg so that they can generate a cough. Minute ventilation should be less than 10 litres per minute so that they're not hyperventilating or tachypneic. Ventilation mode could be pressure support ventilation or CPAP of 5 centimetres of water. They should have a spontaneous breathing trial depending on the unit, which again lasts for about 20 to 30 minutes with appropriate levels of blood gases determined by the unit. So PaO2 should be at a good level and PaCO2 should be at a good level. They should be afebrile with no electrolyte or acid-base derangements. The nurse's role in weaning is to assess the medical criteria for weaning and that they've been met. Weaning should only occur during the daytime when there are lots of healthcare providers around, nighttime not. Explain the process to the patient and reassure them you're a patient advocate. Place the patient in a position of comfort, which is typically going to be at about 30 to 45 degrees, if they are allowed to be in that position, because they are, as we should indicate, hemodynamically stable, or they don't have any mechanical issues such as spinal issues or pelvic issues. Ensure that the patient's airway is clear and always remain with the patient on the commencement of the weaning process. You're a patient advocate. They want to feel confident and secured. Monitor the physical, psychological and vital signs, and especially their arterial blood gases. And ensure that the airway management equipment, resuscitation equipment, is always available and relevant for that patient. What are some of the methods of weaning? T-piece trial, continuous positive airway pressure ventilation, synchronized intermittent mandatory ventilation with pressure support, or pressure support ventilation. They're typically the more common ones. Are any better than any other? I don't think the evidence in the research indicates any one is better than any other. Personal preferences. I prefer SIMV with pressure support ventilation. T-piece trial basically means that you have a T-piece. This is T-shaped tubing connected to an endotracheal tube or a tracheostomy tube, and the patient's breathing spontaneously, and it's used to deliver oxygen to an intubated patient who is weaning off invasive mechanical ventilation. The goal is to progressively increase the time off the IMV. CPAP weaning basically means the patient is breathing spontaneously, but they're still connected to a ventilator. But there is no ventilatory support. The goal is to progressively decrease the CPAP to 5 centimetres of water with normal arterial blood gases. Then you've got synchronized intermittent mandatory ventilation, and this is probably the most common mode for weaning, plus or minus using pressure support ventilation. And the goal is to progressively decrease the number of mandatory breaths or control breaths until they get down to the pressure support, or they get down to the CPAP, depending on which is being used. So they're breathing only spontaneously, spontaneous breathing. Pressure support ventilation is probably more commonly used these days. The patient breathes spontaneously and the ventilator just supports their spontaneous breathing. Pressure support is typically commenced at 10 to 20 centimetres of water and is gradually reduced as the patient becomes more independent. Stronger blood gases are effective. The goal is patient tidal volumes of greater than 5 mils per kg and a respiratory rate of less than 25 breaths per minute. The medical criteria that is considered that the patient has failed their weaning process is they have level of consciousness changes, they become agitated, aggressive, non-compliant, they activate their sympathetic nervous system, which is demonstrated in the form of things like tachycardia, hypertension, increased sweating. They have abnormal vital signs, tachycardia, as I said, respiratory rate becomes high, they become hypotensive, or in other circumstances they may become hypotensive. They demonstrate work of breathing increases, accessory muscle uses, that's what work of breathing refers to. They become dyspneic, they may even become cyanosed. Their blood gases become abnormal. So pH may demonstrate acid-base problems such as a respiratory acidosis, pH of less than 7.32, with now a CO2 that is greater than 50. Or they may demonstrate hypoxia in the form of a PaO2 that is less than 60 on a higher dose of FiO2. Or their SaO2 or their SpO2 may become less than 90%. These may indicate failure to wean. So the take-home message again is that yes, science is important, such as mechanical ventilation, but always remember that you need to care, be an advocate for the patient, and in conjunction with the science, this will mean that you are an effective healthcare provider. So thanks again. Thanks for reviewing part 4, and if you're interested, go to part 5 and any other Dr. Manny Learn Shops which are available on YouTube.